and I'd like to introduce, without further ado, the third Refugee Health webinar called Conducting a Comprehensive Refugee Health Assessment. So before we start, I'd like to acknowledge and pay respect to the Whadjuk Noongar people upon whose land we are meeting. I honour their elders, past and present, and recognise the continuing connection of Aboriginal peoples to their lands, waters, and culture. I also recognise the diversity and strength of Aboriginal peoples and the significant importance of self-determination and cultural knowledge in supporting the positive health and well-being of the whole community. So for your information, your microphones and cameras are enabled. We would love to see you today, and Dr. Gracie would like you to interact as much as possible. So if you have any questions, please drop them in the chat and she will answer them throughout the presentation. So please fire away if there's anything that she says that you have questions about. This is our webinar disclaimer, and that can be found on our YouTube videos. And I'd like to introduce Dr. Gracie Vivian, our speaker for today. She's a GP at the Humanitarian Entrant Health Service at the Public Health and Clinical Excellence Centre. So over to you, Dr. Gracie.
Thank you very much for the introduction, Michelle. I will just share my slides with you as we chat. I appreciate the opportunity to speak today. I've been working at HES, which is the other name for the Humanitarian Entrant Health Service since 2019, and really enjoy the work that we do there. You'll learn a little bit more about that as we go along. So thank you very much for the acknowledgement of country. I'll move on just to provide you with some context as to where this webinar will sit in the series of 6 that we have on offer through WAPA. This is the third out of 6. We'll talk about the Refugee Health Assessment today. The next webinar, number 4, we'll talk about how to manage common conditions. Number 5 will have a paediatric focus, and then the last one will be immunisation catch-up plans. Now, these are the learning objectives that I've prepared for today. We're going to have a look at screening that patients may or may not have had prior to coming to Australia and after arrival. We'll talk about a Medicare benefit schedule health assessment. We'll look at the guidelines that we can use to do this health assessment, chat about investigations, how to make a plan, who to refer to, and if we have time, we'll have a look at some of the common conditions that we see coming through our service and think about ways that practices can improve access and overcome obstacles to healthcare. Now, as Michelle alluded to, the number of attendees really does lend itself to having an interactive or intimate discussion, should you wish. So if you do want to share experiences, ask questions, please just sing out, use the chat box as Michelle mentioned. I'm more than happy to do that as we go along. Throughout the slides, I've put some links in. So if you get a copy of this presentation afterwards, you can hopefully use it as a resource, click on some of the links. At the end, there will also be some useful resources too. Okay, so the first section that we'll talk about are the pre and post arrival health assessments. What actually happens? In order to understand that, we need to have a look at who gets what health assessment when. So this is a very simplistic table, but it outlines for you on the left here who normally gets seen at HES and who receives what. So in that first column, refugees. These are usually people who've made a claim for asylum that's been accepted by the UNHCR, the UN High Commission for Refugees. This usually happens offshore. All of the paperwork and processing is done offshore. They get accepted into the HSP, the Humanitarian Settlement Program run by the federal government, and then arrive into Australia. When they arrive here, they have a permanent visa with rights to Medicare, Centrelink, etc. Before they come, they have extensive medical checks. There's lots of acronyms, I know, IME and DHC. We'll learn more about this on the next slide. When they come to Australia, they are then referred from Red Cross, who are our HSP provider in Western Australia. As I'll allude to a little bit later, Red Cross do a brilliant job of basically helping to settle and orientate newly arrived refugees into the country. They pick them up at the airport, help them find accommodation, enroll them in Medicare, enroll them in English classes, teach them how to use public transport, and the list goes on. So very comprehensive, welcoming service. Patients are referred to us at HES, and they undergo a comprehensive assessment, which is voluntary. Nothing is mandated. So that's our usual client at HES. On the right, you have the column there for asylum seekers. These are usually people who've made a claim for asylum, but the outcome is yet to be determined. Usually these people are onshore in Australia when that claim is made. These group of people have a different variety of visas, temporary, bridging, etc., and they have variable rights to Medicare, Centrelink, and so forth. Before coming to Australia, they may have had little to no health screening, and then after arriving, there may be some basic screening from the perspective of infectious diseases through Bupa, I should say, who's the private provider for migration visas, but there's no formal referral pathways for these people through to us at HES or to any other agencies. So these are the groups that really fall through the cracks. These are the groups that tend to be quite vulnerable in terms of need, and it can be difficult to identify them. Let's move on now back to the refugee group to see what happens in terms of health checks before they come to Australia. Now, this is a hugely busy slide. You don't need to know any of it. It's there really just to impress upon you that 2 health checks are undertaken before coming to Australia for refugees. So that's the immigration medical examination in the top left, and in the top right, the departure health check, which is basically a fitness to fly check to ensure that the patient is safe enough to get on a plane. As you can see, this is pretty comprehensive. There's a lot that's actually done to support and to make sure that the health and well-being of refugees coming to Australia, that some of those needs are met. What happens for refugees when they get to Australia? As I mentioned, they're referred from Red Cross through to us at HES. We aim to identify health issues which may affect the well-being of these newly arrived refugees. Traditionally, when our service started in the 70s, this was all about infectious diseases, making sure that tuberculosis was screened for, amongst other things. But as you can imagine, more holistically over the years, we understand that well-being isn't just about preventing infectious diseases, but about detecting other biological, psychological, and social issues which may become relevant to that person in their new life here. So when we see people, we see them in groups with an interpreter, and it's a free service. Usually we spread our appointments out over 2 visits. The first is where the nurse does a comprehensive interview, bloods are taken, and then at the second appointment, the GP or our nurse practitioner will review the bloods, instigate treatments, make a plan, and do a catch-up immunisation schedule, which is initiated by our nurse. We also provide health education. And really importantly, we refer onwards to our parties in the community who really help support our clients, and I'll refer to this again later. And then after this, we discharge to general practice. So this is where your role comes into play. I'd like to highlight at this part that this is where you can see a large disparity between the pre and post arrival health assessments that are offered between those 2 groups, refugees and asylum seekers. Refugees are really pretty well covered. They have comprehensive assessments on both ends. but asylum seekers don't. And this is something that perhaps is underappreciated in our general society, and it's worth underlining for yourselves in general practice. It's important to note that you can access the health assessment that we do at HES. We take all of the information that's gathered over the 2 visits from the patient and put it into a discharge letter. It really is quite detailed, and we email or send that letter through to the patient's general practitioner if they have one. And if they don't have one already, ideally we print it out and give them to the patient to take to their GP if there's time to do so within the consult. So if you have a new patient and you determine that they have been to see us, by all means request that information. I think it would be really helpful for you. We just need written consent from the patient. And please be aware that all of our bloods are done at Path West. You can access all of those bloods as well, which can help avoiding double up and so forth. Now let's move on to health assessments. It's good to remind ourselves of the general benefits of a health assessment. Obviously, there's lots of different Medicare health assessments that are available. We've got the over 75s, we've got the 45 to 49-year-olds, health assessments for those with intellectual disabilities, for those in residential aged care facilities, etc. So this one is for refugees. In general, we've got some positives. I'm not going to go through each dot point up the top, but there's consistency and ease of access and reading. It can really help save time, assist with the communication. And if we have a look at the bottom of the slide, specifically for our cohort, it can really help to identify gaps in their pre- and post-arrival healthcare. And it can really help with their settlement if done as early as possible after arrival. We know that the early settlement period is a period of particular vulnerability for a lot of our patients. As you can imagine, coming to a new country, not speaking the language, perhaps the culture is very dissimilar to the one they've come from. There's a lot of disorientation. So having a health check and feeling heard, and as if some of the outstanding health issues are going to be addressed, is a really important way to help smooth that journey for our patients. Now, I wanted to highlight who should be offered a refugee health assessment. Now, essentially, all people from refugee-like backgrounds should be offered one of these health assessments. That includes refugees who've had their claims for asylum accepted. That includes asylum seekers who've made that claim for asylum but haven't yet had an outcome granted for them. When should it be done? Ideally as soon as possible after their arrival, but it could be any time after their arrival. So you may have a patient pre-existing who you realise has been in Australia for some time. Maybe it's been more than a year, maybe it's been 2 years. They could still benefit from a refugee health assessment potentially. I wanted to ask yourselves if you're happy to answer. This is also very curious for me in general practice to see what other people's practice is. How do you in your day-to-day work identify patients who may benefit from a refugee health assessment?
Please feel free to unmute yourselves and jump in.
There's absolutely no pressure. I might just speak up here. First of all, your client or your patient may bring their HES discharge letter with them. We hope that they do this if we've been able to physically hand them one and instruct them to see their GP within a certain time frame in a sealed envelope with their name on it. Hopefully it gets handed to someone in general practice. Or the discharge letter comes into the electronic inbox in the self-practice software. More often than not, it may be a clinical suspicion or an inkling or an inquiry on your behalf that perhaps this patient may have been a refugee or had a refugee-like background. When did they come to Australia? Where did they come from or transit through? Maybe they speak another language. Maybe they've advised you they need an interpreter. These patients may be brought in by a support person from their family, from CARID, who I'll refer to later, Red Cross or another NGO worker, and perhaps they're self-referred. So maybe, as I said before, they're a pre-existing patient. Maybe through the course of your longitudinal relationship with them, you learn about their past. So this is really important, identifying who could benefit from a refugee health assessment, because with this, we really want to capture that vulnerable population of people who kind of fall through the cracks, and that's mainly our asylum seeker kind of cohort. It's important to note only a subset of patients who can benefit from a refugee health assessment may be eligible for the Medicare rebate associated with the health assessment. So let's talk a little bit more about that Medicare rebate now. So as GPs, you'd be familiar with the MBS and with the health assessment item numbers here, the 701, 703, 705, and 707. These are time-based, and the eligibility for refugees is essentially two. They need to be a refugee with Medicare, and they either have to have the right visa and have held it for less than 12 months at the time of the health assessment, or first entered Australia less than 12 months ago. So this is quite a narrow scope of patients who may be eligible for the MBS rebate. The time base is significant there, and the visa eligibility criteria. As you can see, these are the visas that are listed. At HES, we see everybody except for the bolded visa number there, the 790. In practice, though, we mainly see the 200s subclass, which are our main refugee visas. Again, this is where it gets very finicky, and inquiring about visa, date of arrival into Australia really becomes relevant from the health assessment point of view. Of course, it's important to determine whether a health assessment has already been billed. So you can do this through HPOS on Proda, or get your practice admin staff to check this for you if required. It is really important to note, and I should have brought this up earlier, at HES, we're funded by the state government, North Metro Health Service. So we do not bill to Medicare, who are a federal service. That is to say, we perform the refugee health assessment as a clinical item, but we don't bill for it under Medicare. So clients who see us may well and truly benefit from a review of that health assessment from their GP, so long as it's within that year, and the MBS item still remains open to be billed. So from a GP perspective, I think that's an important thing to note.
Dr. Gracie, we've just got a question that's come through.
Yes,
how
please.
long do refugees stay at the site of arrival in Australia before joining the society relative to results review in case they need further reassessment or treatment of anything? In addition, has there been a situation that a client arrived and needed to be quarantined due to any illness or infection?
So forgive me if I'm wrong, not being able to read it. The first question was about how long a patient may have to wait before being able to enter into Australian society. Is that right?
How long do they stay at the site of arrival in Australia before joining society relative to results review, in case they need further reassessment or treatment?
And then the second question was about quarantine. Thank you. So essentially, upon arrival, patients are immediately introduced to wider society. They're accommodated usually in hotels or accommodation until they can find more permanent residence. So generally, clients are not quarantined. The reason for this as well is partly due to the departure health check that patients will have before they leave. This includes things like screening for tuberculosis, doing a set of OBS, providing albendazole, ivermectin, plus or minus praziquantel. So these are all treatments for worms, strongyloides, and schistomiasis, respectively. So there is a bit of a safeguard against acute infections which could manifest in Australia. Should also add that includes a chest X-ray as well, usually at some point before the patient flies to Australia to exclude active TB. So there's no reason really for newly arrived refugees to be quarantined or to be sort of staggered in their introduction to living in Australia at large. I hope that answers your question. Please do sing out if further clarification is needed.
Thank you.
I'll have a chat now about the MBS requirements. This is taken directly from the website. You're probably familiar with it. To summarise this busy slide, essentially a full assessment means history, examination, investigations, making a plan, and then following up. So this is our bread and butter as GPs. It's worthwhile to mention if you need to use an interpreter through TIS, that time gets included in the length of time of the item number. Also, practice nurses can get involved, and if they're sharing the workload with you, handing over, and you're facilitating the health assessment together, their time can also get included as well. Medicare do note that it's not just about time, but the level of complexity of patients. And as you can appreciate, some patients are really straightforward, others have quite profound complexities to work through. So just a slide here to reiterate the point about how there's two different nuanced things we're talking about here. There's the clinical refugee health assessment, which is the history examination, investigations, etc. Everyone from a refugee background at any time after arrival could benefit from one of those. Within that group, Medicare offer a health assessment rebate for a very particular subset, refugees with a certain visa and who've been in Australia for a certain time or had their visa for a certain time. Hopefully that sits well. Now, how do we do this health assessment? So let's use some guidelines. The guidelines that we use, the ones on the right here, the ACID guidelines. These come from the Australian Society of Infectious Diseases. It's a PDF document you can find online. If you print it out and bind it, it turns into a very, very thick book. So it's not super user-friendly, which is why the Australian Refugee Practice Guide is used. It's exactly the same content, but delivered in an online-friendly format so you can have a look at all the different tabs and access the information within consults. Using a template can be really useful, as I'm sure you appreciate. This refugee health assessment template is available online in RTF format, so you can upload that to Best Practice or whatever other software you're using, have it auto-filled, and just enter in the details that you need to as you go. This is a particularly good template because it gives you lots of hints along the way about what to ask for as well. Okay, so what does this consist of? First of all, we cover the usual. Any first-year medical student will be able to rattle off this list: demographics, presenting complaint, history, presenting complaint, past medical history, medications, allergies, social history, family history, etc. we do add in a few other things as well. So for demographics, we want to know about the 5 identifiers, which are language spoken, need for an interpreter, country of birth, ethnicity, and date of arrival. So there's been a big push from a lot of members of the RACGP Special Interest Group for refugees, as well as REANA, which is another acronym standing for the Refugee Health Network of Australia. And the push has been to incorporate these identifiers into practice software and into referrals that we at HES provide and other people in this space. And the reason is, this is vital information to know for your patient who's sitting in front of you. It also helps to capture data about this cohort. What are the gaps? What are the strengths? Ethnicity, how is that relevant? It is really important for a lot of our clients who come perhaps from minority ethnic groups that have been persecuted within their own countries, and being able to appreciate the nuances of this and to not cause further harm by presuming that they're part of the group that has done the persecution is really important. Date of arrival, really important from an MBS health assessment perspective, as we've talked about. Need for an interpreter. If this is really obvious and visual to you on your practice software, you know that you can prepare for the subsequent visits with greater ease. So hopefully that makes sense. Now, past medical history. There's a few extra things that we want to know about. So injuries and accidents. A lot of the patients that we see have undergone physical assaults or been involved in blasts or bombings and so forth. Some still have scars or ongoing disabilities as a result. We want to know about history of infections. In particular, obviously there's tuberculosis, hepatitis B is more prevalent in a lot of the countries where our clients come from, HIV, syphilis, etc. Non-communicable diseases all over the world, hypertension, dyslipidemia, non-alcoholic fatty liver disease, these sorts of things are very, very common. Preventative care. A lot of our clients may not have had access to cervical screening, mammograms. One that surprised me when I started at HES was the amount of pathology relating to hearing, vision, and teeth. So it's surprising to me still how many times I'll look at an ear, patient hasn't really reported any symptoms, but they might have chronic suppurative otitis media or a perforated tympanic membrane, perhaps from an infection or an injury many, many years ago, and they've just learned to deal with it. Vision is important, and dental caries, really common in some of the young children that we see, also in adults who haven't had access to dental care. Disability and function is really important. More and more in the last few years, we have seen a higher arrival rate of patients with quite severe disabilities, which have ranged from anything from neurological disabilities. One lady who I saw recently stated she had a tree branch fall on her many years ago, which left her hemiplegic. Things like this, congenital illnesses. We've seen patients with Down syndrome, autism, psychological illness as well. In this cohort, we might want to consider doing a HUDAS. I'll show you a picture of this in another slide. This comes from the WHO and stands for the Disability Assessment Scale. In our social history, there's other things we want to ask about as well. So in addition to SNAP, under alcohol and other drugs, we might want to consider betel nut, shisha, and chat. We might want to think about food scarcity and nutritional status. So this is really common in our clients. Perhaps before coming to Australia in a transit country, they weren't able to access meat or fresh fruit and vegetables. We also want to know about what their access is like here in Australia. Do our Muslim patients know where to get halal food? Do they have enough money after they've paid their rent to be able to buy foods that are culturally appropriate? We also want to know about the level of education attained by the patient. We've had some patients with master's degrees. We've had others who are adults who've never attended school. So you can imagine that pitching your explanations will be very different for both groups. Their level of health literacy and digital literacy needs to be taken into account as well. Employment is important, and housing, especially in this context at present where there's a lot of housing stress. We try to see our clients within a month of them arriving, and this routinely comes up as an ongoing source of stress. They're looking for a home. They can't find a home. It's really disheartening. Perhaps they're staying at a hotel, but they've got young children and it's driving them nuts. Or perhaps they're staying with family who already live in Australia. In these scenarios, you tend to see multiple family groups living concurrently with multiple family members, multi-generations, which is fine for a short period, but becomes really trying after an extended period of time. These are images of betel nut on the left, shisha in the middle, and then chat, the green leaf on the right. Following on from history, in addition to the usual, we also want to ask about migration history. Now, I've mentioned already some of these issues. The one that I haven't is, have you spent any time in detention centres or refugee camps, as well as countries of transit? So a lot of our patients may have had very complicated migration histories, transiting through multiple countries or perhaps back and forth between countries. Very recently, a lot of our Afghani patients who maybe fled to Pakistan or Iran in the past have had to enter a different country or return to Afghanistan in order to come to Australia. And that's because Pakistan recently closed their borders to Afghan refugees and expelled some, and of course with the war in Iran as well. Psychological history is one we really want to know about. So what's happening in their life now that they've come to Australia? What are the stresses and what are their supports? We do psychological screening, and for this, consider the STAR MH. Again, on the next slide, I'll show that to you. It stands for something really obvious. I think it's something like Screening Tool for the Assessment of Refugee Mental Health, and is validated and created especially for our clienteles. A lot of our clients have trauma. So I think this has been alluded to in the last webinar, but what we want to do is to screen for it, but to not re-traumatize. So often I'll ask about how their lives at the moment may or may not have been affected by what's happened in the past. In fact, in the Refugee Health Assessment template that I showed you earlier, they give a really nice little line to consider for screening for trauma. They say, bad things have often happened to people who've been forced to leave their countries. I don't need to know the details about what you've been through, but has anything happened to you or your family that could be affecting your health or the way you're feeling now? So this is really nice. It shows a respect for what may have happened in the past, but brings the patient into the present. Certainly, GPs who have the time, the skills, and the context in which they can safely explore trauma with their patients are more than welcome to, but often in our busy clinics, knowing that there has been trauma in the past is enough, and then creating that space for it later if you wish to do so may be the safer way to go. Realize I'm racing through here. Please do stop me if you've got any queries. We want to know more specifically about women, children, and then sexual health. So for women, we want to know about their obstetric history. A lot of our patients have had many children with a higher rate of miscarriages, postnatal deaths, and even deaths of children. We want to know about their preventative care. We want to inquire whether they've had female genital mutilation or cutting, or experience intimate partner violence. These issues are more common in the cohort that we see for a variety of different reasons, one of which is the stress that settlement places on families. We want to know if the woman has had an arranged marriage. Arranged being different from forced, arranged being suggested by external parties but consented to by those involved, and obviously forced is done against their will. We know that this is illegal in Australia. Families that have a history of forced marriage within them may be more likely to encourage the same for their children. So inquiring about this is really important, and educating them about laws as well. Contraception is something to touch upon as well for women. With regards to children, we want to know the whole history. Webinar 5 is going to focus on paediatrics. The one thing I'll mention there is the education history. So a lot of the kids we see may have had gaps in their learning. Maybe they attended year 1, they were kind of on the move for year 2 or 3, and then they got to year 4, and then their education fell off, and now they're 16. So you can imagine the kind of impact this has on a young person coming to Australia, being enrolled in an IEC, an intensive English centre, I think is what C stands for, school, and having to learn English and catch up with their education compared to their peers. Sexual health, we also want to know about STI risk factors, whether they have any symptoms. We no longer routinely screen for STIs, but do it on a case-by-case basis, based off of some studies done some years ago, which showed that refugee clients don't have a higher prevalence rate of STIs like chlamydia or gonorrhea than the general Australian population. So that leads me on to, sorry, not investigations yet, examination. Apologies again for the very busy slide, but a few key points from this. Thinking about nutritional status is really important in our clients. We've talked about ear, nose, and throat pathology. I'll highlight their feeling for the cervical lymph nodes, and that's relevant when looking for TB, predominantly extrapulmonary TB, which we can always forget about. It's hard to remember sometimes. TB in itself doesn't really have any classic or obvious respiratory signs to lend itself to easy detection, but we should examine the respiratory system anyway. Moving back up again slightly, checking for visual acuity, or if there's no time, just asking about visual issues. Checking for murmurs. I'm surprised by how many incidental murmur findings I come across in clinic. We want to feel for hepatosplenomegaly from an infectious disease point of view. Malaria, leishmaniasis, Chagas disease are all potential infectious diseases that our patients could have because of where they've come from. We look at scars and other skin sort of issues too. And then the rest is really if indicated. I might draw your attention to the highlighted word down the bottom, the RUDAS. So as I mentioned, we've got a lot of patients coming through with disabilities. Sometimes that can be related to intellectual disabilities. We've had more elderly patients coming through who've reported memory problems. In these scenarios, the RUDAS, which stands for the Rowland's Universal Dementia Assessment Scale, is much more culturally appropriate than the mini mental state examination. As you're aware, the mini mental state examination asks things like spell world back to front, who's the Prime Minister, what are serial sevens backwards from 100, which requires cultural and education levels that our patients may not have. So I will then move to this following slide that will show you the 3 different screening tools that I've mentioned. The first one is the Rudis. Really easy to do. I had a medical student sitting in with me this Tuesday. She'd never seen it before, but she was able to, after reading through it, basically do it straight off the cuff with the patient we had there, which was very useful. This is the HUDAS about disability and function. This is a really nice way of having a look at different aspects of a person's life and seeing where their strengths and vulnerabilities lay. So it touches on things like ADLs, functionality, sexual health, finances, how much their disability impacts on their ability to form relationships and on their family. And lastly here is the STAR-MH, which is the mental health screening tool. It's got 10 questions in it. Essentially, it's suggested you ask the first 2 questions. If the answers are no to either of those, you can stop your screen there. If there's a yes answer, proceed with the rest of the questions. I won't delve into those in any more detail, but the links are below should you be interested in using those. Now, investigations. What do we test for? So the investigations that we do at HES are listed in front of you. They are slightly different from the Australian guidelines. There's a few differences which include things like we test everybody for Hep C, not just for a particular cohort as suggested for by the Australian acid guidelines, and there's a few other little nuances as well. Going through these, you can see them divided into groups. So there's ones that all clients have, full blood picture, iron studies, etc. There's tests that are age-based. So HIV and syphilis serology reserved only for 15 years and above, with exclusions listed there, and a few others depending on age. Our third group on the left is based on where a person comes from or has transited through. I'll show you a table on the next page that helps with this. On the right are our risk-based investigations. So from the top, the first row there is really just what we would do in general practice for the standard patient who comes in, who wants a checkup or requests checkup bloods. We tend to do them from 35 years and above, as per the RACGP Red Book, because a lot of our clients do come from higher risk ethnicities. The next row there, I talked about STI screening before. We only really do that if requested or if symptomatic. B12 and folate, I tend to do this personally for everybody because we see patients who've arrived less than 6 months ago, and vitamin B12 deficiency is one of our top sort of conditions that we see. And then the others, I might just skip over to stool samples. We don't do this as a blanket rule for everybody, but only those who have symptoms, pediatric growth faltering, or eosinophilia that hasn't resolved after albendazole. So eosinophilia, as you're aware, has 2 main differentials in my head, 2 big groups, thinking of sort of asthma or other allergic type diseases, or worms. So in our clients, we go straight to managing potential worm infections with albendazole and follow up with a stool. You've then got preventative activities for health, and then the chest X-ray and sputum if you're concerned about TB. So just a little word about TB there. Symptoms suggestive of this are that triad: cough, fever, unintentional loss of weight, usually for a duration of 3 weeks or more. Even without symptoms, if someone returns a positive quantiferon, which is the screening blood test we do for latent TB, these patients will get referred to WA TB control. That's the statewide service that manages TB, potential or confirmed, and very conveniently, they sit in the same building as us, just in the next corridor. Hopefully no questions about investigations. I'll move on to this, thanks Michelle, to this cheat sheet, which can tell you, based upon the common countries of origin that we see patients from, whether or not they need to be tested for schistosomiasis or malaria. And these are our red flags. In the top left-hand heading, it's really the big infectious diseases we don't want to miss. Obvious things like malaria, TB, HIV, etc. I say obvious because we don't want to miss them, but not because their clinical presentation is obvious. Often we miss them because they present in insidious ways that can be really hard to detect. I've included some orange and yellow flags as well for you to peruse through. Now, just an information slide on the most common countries of origin that we see patients from 2024 data. And then on the right, the top conditions that we treat. You can see that there's some overlap between what you might just see in sort of ordinary general practice here in Perth, vitamin D deficiency, iron deficiency, etc. I won't labour on this point too much because Zoe in the next webinar is going to expand on this fully, how to treat common conditions. Again, another busy slide, but I hope one that's helpful for you with the links. What do we do with regards to a management plan? So further tests, further appointments. Does our client need any more preventative health checks, chronic disease items, immunisation catch-up plans? Referrals, so knowing who to refer to can be really tricky. I'd always say that I think clinician assist is really useful for this because that information stays up to date. In general, our top 5 would be the Catch Refugee Health Service. So this is where we send our kids. This service encompasses both the Refugee Health Service, which is located at PCH and run outpatient clinics and are very responsive to our requests for help, and the Refugee Health Team, which work in the community, visiting families, helping to support and settle clients for a period of, I believe, up to 2 years. So this is an excellent wraparound service, very comprehensive. They like to see all refugee and asylum seeker children. We offer a referral to all our young children to see them, and they accept clients up to 18 years old, not just up to 16 like the rest of PCH. So please do utilise their services if appropriate. Isha, we refer to very commonly, Women's Health Centre, Medicare only, free, interpreters are used, and there's 2 locations in Moorooka and Gosnells. ASSETS stands for the Association of Services to Torture and Trauma Survivors. There's an equivalent in each state. Again, they do an excellent job of meeting the needs of our clients. You don't need a Medicare card to see them. There isn't a time limit for when our patients can go to see them. They do need to have come from a refugee background and have experienced trauma, but I think it's very legitimate to have a broader view of trauma, even those that haven't been physically or sexually assaulted, by virtue of the refugee journey and the inherent disruption and disorientation related to that in my mind would count as trauma. And certainly ASSETS have been happy to accept all the referrals that we've sent their way. Number 4, I've mentioned the WATB control program already. There's also the Lion's Eye Institute, which Dr. Hessam Razavi started up as a free service for patients with Medicare. They can have an eye check, they can get glasses for free, and anyone who has ophthalmological issues can see an ophthalmologist. So they're really good to know about. Other mental health services. So at the IEC schools, they all have a school psychologist who are able to be contacted by phone if you need to link in a client. Culturally diverse psychological services require a mental health care plan and then can offer 10 sessions to their clients. And then we've got some others, CRS, dental, disability, and other. I'll draw your attention to Perth Multicultural Health Link, which is a fairly new service that, as I understand it, basically act as case managers or guides for clients who are finding it hard to know where to access what service. This can be really useful for a lot of the asylum seeker patients that you may see who don't have the support of CARID or potentially of Red Cross.
Hi, Dr. Gracie. If I can just mention, if I could just quickly mention that WAFA Clinician Assist also has resources on refugee health as well. And just a time check, we've got 5 minutes left.
Perfect. Thank you. Yes. I found Clinician Assist really useful for identifying resources for our clients as well. So thanks for that reminder, Michelle. I'll wrap up shortly. Essentially for ongoing care, there's obviously yourself. GPs are central to that process of managing ongoing care needs. To the right, other providers in the community. So I've spoken about some of those referral pathways. Red Cross and CARID. So apologies for some of the confusing wording there, but essentially Red Cross, as I've mentioned, support our newly arrived refugees. CARID, who stand for the Centre for Asylum Seekers, Refugees and Detainees, try to support asylum seekers who basically aren't picked up through the HSP system that Red Cross supports. They are totally run by donations, but do a fantastic job of doing their best to aid their clients. One that a lot of people forget about is the SETS program, which is federally funded, where they can provide extra support to certain refugee families as well. Now, I'm going to leave it there. The rest of the presentation basically talks about challenges that newly arrived refugees may face in terms of post-migration stresses, the barriers to healthcare, and then offers some practice tips that you might want to consider to reduce some of those barriers. And then after that, I've just listed some resources that may be useful for learning activities, clinical resources, networking, and practical aids. Thank you very much for your attention on this cold night. I'll hand back over to you, Michelle.
Thank you so much for the valuable information. Does anyone have any more questions for Dr. Gracie? We've just got a couple minutes for question time, and then I'll wrap up for the night. And if you do, please feel free to unmute your microphones and just jump in. The next webinar will be on common conditions and case studies in refugee health, which Dr. Gracie had said, with Dr. Zoe, and that's on the 21st of July, so this time next month. As also discussed, these are the Clinician Assist WA resources. They will be included in the slide pack so that you can access the links and everything, along with Dr. Gracie's links as well. And finally, we can't really run our training without your contribution. So if you could please leave your feedback for us and for Dr. Gracie, that would be much appreciated, as your feedback informs our future training and what you'd like to see from us. So does anyone have any further questions at all, for questions or comments? If not, thank you for your questions throughout the webinar, and thank you so much for taking the time to join us tonight. If you do think about any questions, please do use the feedback form and pop them in there. Then I'll feed them back through to Dr. Gracie and we'll answer them in an email to you. Thank you so much, everyone. Oh, was that a question?
Someone is typing in the chat, Michelle.
Yep.
And
please do feel free to unmute yourself as well if you do need. Sorry, Jody.
the typing stopped.
Oh,
I think
It
it's
must have been me, sorry.
Yeah.
I just wanted to say thank you very much. I mean, the emotional contribution that you make to caring for people is, yes, I mean, there's no words to it. So thank you for the work that you do.
Thank you very much, and really appreciate your attendance tonight. I should also add, we're not a clinical advisory service as such, but if you do have any questions, that same email address where you can ask for discharge letters, so long as it's not urgent advice, feel free to contact us. We're really happy to troubleshoot things and to support you in the community as well. Thank you.
thank you for your feedback. And with that, I'll wrap up. Thank you everyone for taking the time to join us tonight. I hope you have a lovely rest of your night, and please keep an eye out for your post-webinar email with the resources and the details for the next webinar upcoming. Thank you very much. Have a great night.
Thank you.
Bye.